Welcome to TraumaCast. It's like a podcast, but about trauma. Listen and learn from our team about current trends, new research, and continuing performance improvement efforts. This education is available for CNEs. Successful completion includes watching or listening to the entire session and completion of the attestation and evaluation. The link for the attestation and evaluation is located at the end of this video. We hope you enjoy, and please let us know what you think. Hi guys, thanks for joining us for another TraumaCast. Today is a little bit different. We're going to be jumping into our research role, our research arm of the trauma department, and we will be talking about a research that's starting in November in just a few days. And this is going to be affecting a lot of our trauma patients. So we have two special guests here today, Dr. Bird, our medical director of the trauma department, who will be also heading the research arm of the study in this hospital, as well as one of our research coordinator, Erin Moon. If you guys want to say hello.
Hello. Hi, guys.
And of course, we have our amazing trauma program manager, Jen Fritzine, with us today. So we're just going to jump in and get started. And Dr. Bird, I just wanted to see if you can give us an explanation of what the MATIC-2 study is that's going to be started, and like just a little bit of background of why the study came about and why we are part of that.
Yeah, the MATIC-2 study is a study looking at what strategies are best for managing injured children who present to the emergency department with significant bleeding, and basically patients who are undergoing massive transfusion protocol. And the study is trying to address whether evaluating two different, it has two different arms, evaluating whether or not whole blood or component therapy is better for these patients, or whether getting TXA does any good. So the second arm of the study is TXA versus placebo. And we are one of approximately 20 sites that are participating in the study. We're not the main study the main institution organizing a study that's being done through University of Pittsburgh. We've been preparing for this moment on Friday, right? Friday is when we start for the last year with lots of preparation. And that preparation has involved talking to people in emergency medicine and emergency department, nurses in the emergency department, PICU team members, physicians and nurses, a lot of involvement with the blood bank for obvious reasons, and we're hoping that this study goes off without a hitch. And we anticipate enrolling approximately 10 patients per year at our site. And let me just sort of outline what we envision happening. So on November 1st, when a patient comes in who the team believes is bleeding, an injured kid who we believe is bleeding, that patient will be eligible if they meet criteria for this study if the massive transfusion protocol is activated. And we basically need the patient to meet two of three criteria. They have to be hypotensive and tachycardic, or have some obvious source of visual bleeding, like if a patient has obvious, like the blood is soaked, the bed is soaked with blood. We need two of those three things to be met, and the patient has to have massive transfusion protocol activated. And then the patient's eligible for the study. And the way the study works is that each site is for a given calendar year, more or less, is either in the arm of getting whole blood or getting component therapy. And whole blood, for those you may not know, is all the, when you draw blood out of somebody, that's what you get. It has the platelets and the plasma and the red cells all in one bag. And then what we do, the blood bank does, is they separate it into components. And so we're much more used to getting component therapy where you may just give red cells, or you may just give plasma, or you may just give platelets. And so in the first year of the study, starting November 1st at our site, the patients are going to get whole blood. So that means that the first drop of blood that the patients get will be whole blood. And in the blood refrigerator in the trauma bay, we have different drawers that will allow us to pull out the drawer that corresponds to whole blood. And so the patient gets whole blood, and then the patient will get what's called, study drug, basically. And a study drug is either that study drug will either be TXA, tranexamic acid, or placebo. And we won't know, as investigators on the site, we will not know whether or not the patient got TXA or placebo. And then what happens is that we do blood sampling as we normally would for every bleeding patient in the trauma bay who gets massive transfusion protocol. We have the order sets all set to go. So it's a panel of labs that you would normally get. It includes things like, obvious things like hemoglobin and coags and calcium. So there's a panel of labs that we will now get for every patient, whether or not they're part of the study, if they have MTP, massive transfusion protocol, activated. We also are going to get a TEG, and I'll talk a little bit about how this study really helped put TEG on the map for our hospital. But TEG will also be obtained when the patient is enrolled in the study. In other words, when they have the MTP activated. And then the patients, then the only remaining part about the study that involves our clinical teams is that there's research labs that need to be obtained at 6 hours and at 20 hours after the MTP is activated. And that's basically 3 blood tubes that are ordered and sent to the lab, and those orders will be triggered by the MTP being activated in the trauma bay, and a TEG. So at 6 hours and 24 hours, 3 tubes for research labs, which are going to be part of a Cerner order, and then the TEG all over again for those patients to look at their bleeding profile. The study, what the study intends to do is not only to say, what is the best therapy for bleeding kids? What kind of blood therapy transfusion therapy should we be using? Should we be using TXA, or TXA is just a waste of time and money? But we're also part of the reason that these research labs are also being sent is that we're going to look at the patient's biochemical response to the hemorrhage and the therapy that they receive. And this will allow the Pittsburgh site to do some studies to see how patients are responding to massive transfusion. We anticipate, so we've spent the last year getting this study set up. The study is going to go for 4 years, so it's going to be 4 years of enrollment here at Children's. And again, we're hoping to have approximately 10 patients per year. So we're hoping to get up to about 40 patients over time. So it's going to be a long, kind of long enrollment period in participation for us for this study. Just a couple of things that I think are important to know is that we will consent patients, but the consent process for this study is a little different than the typical consent process that you get for some kind of clinical research study. This study is what's termed an EFIC study, and an EFIC study means that instead of getting consent before proceeding with getting the blood sampling and enrolling the patient, we did community outreach to inform our community through social media and through community outreach meetings to inform the community about this study and get feedback about what kind of concerns people might have, and to let the community know that we're going to do with this. So when a patient comes in, they're automatically enrolled in the study if they meet inclusion criteria and don't meet exclusion criteria. And then what we will do is that we will then later make an attempt to contact the family to get a formal consent from them. And this is the kind of method for research studies that are done when there's an emergency therapy that you can't practically get consent from either the patient or from the family. And even if the parent is standing there in the trauma bay, it's really not a great time to be getting what we would believe would be a informed consent. And so for that reason, even if the parents are there, we're really going to look at a better time when people are kind of like when the dust is settled, when the excitement is stopped, when we can really get what we believe is truly informed consent for the study. But the bottom line is that patients will automatically be enrolled into the study by this EFEC process that we did in place, which our institutional review board helped us oversee and approved. And then we will get formal written consent for the study after that point. A couple of questions that come up very logically with this study is that, first of all, what happens if a patient is already receiving blood before they show up at the hospital? And so our Maryland providers and our Washington, D.C. Pre-hospital providers now have whole blood in their transport vehicles that they can give to patients. Since we've now seen a handful of patients that have arrived receiving whole blood. And that's a great thing because if we believe you're bleeding, you're an injured patient, we believe you're bleeding, we want you to get blood as soon as possible. And that can be done in the pre-hospital setting. That's a great thing. So if a patient is already receiving whole blood when they show up, we don't want you to disconnect the whole blood. That doesn't make any sense. We're wasting that blood. So we want to use common sense, continue running that bag of whole blood in. And then in this year where we're giving whole blood, the next unit that you would give would be a whole blood unit, not a red cell unit or a red cell unit followed by a plasma unit. So plasma. So we want to continue. So if they arrive having received whole blood, we wanted them to just simply finish that blood out. And if they need more blood, continue with whole blood. The other thing that is really a great thing that's happened over the last probably year-ish or so is that also in addition to patients getting whole blood in the pre-hospital setting, patients are now getting TXA in the pre-hospital setting. And that's a great thing. So the nuance of the study here is that if the patient got TXA in a pre-hospital setting, we don't give them another dose of TXA. It just doesn't make sense. They already got the medication. They don't need to get it. So what we're doing is if they got TXA, we're excluding them from the TXA versus placebo study arm. And they're only going to be looked at as the whole blood versus component therapy arm. Now, we're a whole blood year, and there's other sites in these 20 sites that are component therapy years. So other sites will be given, when a patient is enrolled, they will get red cells, then in plasma. And if they need platelets, they get platelets. And eventually our site will be one of the component therapy years. But right now, we're going to be the first year, we're going to be that whole blood year. So I think this will answer a lot of sort of basic questions that we have about how to resuscitate patients who are bleeding after injury. And this really requires, as many people as possible knowing about what we're doing and why we're doing it and what we believe the benefit will be. Because we can't be there at every phase of this study. We put the procedures in place to make this happen, but we need the ICU nurses, for example, to be drawing the blood at 6 hours and 24 hours. And so and if the patient's in the OR, we need the OR team to know about this study and to help us support this study. Aaron, any other things that you think you want to add that have come up in our discussions with people about this study?
Right.
Before we do that, Aaron, can you just let us know how we are going to who's going to figure out who's going to be eligible for the study, like in the trauma bay, like just a little bit more, I guess, nuance to understand that who to look to.
Yeah, so for this study, our ED pharmacists are going to be assessing eligibility in the code room when the patient arrives. So we've kind of created a cheat sheet for them and also kind of educated them and worked with them for the past year to kind of get the study implemented at Children's. And so they'll be the ones to determine if a patient's eligible. And if they are, they'll verbalize it to the rest of the clinical team in the code room.
And in Dr. Bird's comprehensive explanation of the study, he stated that there's a order set that's going to be used once the patient is deemed eligible. Jen, can you explain to us that process? Who's going to be putting those orders in and what that looks like? what the team needs to draw so that we can send that the necessary lab orders.
I'll take a shot at it, but Aaron, back me up if I don't get it all. So the order set, obviously, like Dr. Bird said, we're going to draw the normal labs that we do for all hemorrhaging patients, your comprehensive trauma panel. But in addition, there'll be some research labs. Obviously, every child is going to have a TEG drawn that comes in, and there's a lot of nuances to drawing TEG. And I know Dr. Bird was going to talk about how this revolutionized getting 24-hour TEG into the hospital too. But they'll also have these research labs that have to be done, and those are going to be within the massive blood transfusion protocol order set that already exists. So in the emergency department, that is launched by the NAL. I don't believe that the NAL is going to have to hit anything special. They'll be pre-marked. And the labs that are going to be ordered for the research labs, those will be in there for the immediate lab stickers to print out. And you'll also have the orders for the 6-hour and the 24-hour draw that'll be done in the PICU or the OR or wherever the patient is at. Aaron, did I cover it right?
Yes, you did. That's perfect.
Do we want to talk about the special tubes for a second?
Yeah, I think it's going to be key for this audience is at some point today we need to talk about the tubes.
Yeah, so between the TEG and the research labs, there's 2 blue top tubes and 2 purple top tubes, and they're the 2 millimeter fill tubes. And so instead of having nurses trying to figure out which purple and which blue tubes you're going to use, because I know if you go in where you keep your lab tubes, you have like 4 choices of each. So what we're putting together, and I actually just got done doing some of this, is some MATIC-2 research packs. So if you're in the ICU and you need to draw those labs at 6 hours, you just need to get one of these packs. I need to find out for sure exactly where they're going to be kept in the PICU, and so we'll get that information to all of the PICU nurses. And so we will basically have these packs available in the ED and the PICU in order to make life easier for the nursing staff and take out some of that thought process so we know we're getting the right amount of blood to the right place.
Yes. And Dr. Bird, you mentioned that we brought TEG now. We have 24-hour TEG, which wasn't heard of before. Can you talk about a little bit of why TEG is important and what TEG measures?
Yeah, TEG basically looks at the clotting characteristics of the patient's blood, and using the TEG algorithm, we can predict what the nature of the patient's bleeding is and what components should be administered to that patient to address it. So this is a patient that would benefit from cryo. This is a patient that would benefit from platelets or both. And so we've had TEG at the hospital, obviously, for many years. This is used most commonly in the context of ECMO. And we've had it available in our trauma bay for the last probably roughly 2 years. But the problem is that it's been sort of a business hours test. If a patient comes in Monday through Friday, banker's hours, then you can get the tests, mostly because there's a device setup time and procedure that has to be done, and we really didn't have the facility to do that after hours. And what the study allowed us to do, and this is where the study will actually benefit all our patients, is that we now have TEG available for any trauma patient or really practically any bleeding patient in the hospital 24/7. And then this happened because this study got us a new TEG machine and a new device to do the TEG study. So it's a good thing. So, there's a few steps that have to be done with processing TEGs, whether you're doing it part of this study or doing it for any other clinical context. And I think you guys are going to have to help me out. So it has to be hand delivered, right?
Well, first of all, you have to call 15 minutes before you draw it.
Okay. All right. Jen, why don't you give the whole thing?
Yes. And we will have all this information. It lives in the trauma app, just for everybody to know. If you go to blood and lab folder, you'll see TEG, and it will have all of this spelled out for you. We will also have it posted in the NAL area of the trauma bay. But you need to call the lab and let them know you're running a TEG because they have to take a few minutes and turn on the machine and get it QC'd. Once they're ready, once you draw it, you put it in your blue top tube. You need to make sure you invert it a few times so it can mix with the citrate. And then that lab cannot sit on the counter. It has to immediately be given to the NAL, who can hand it off to the transporter, who will take it to the lab, and they physically have to hand it to somebody. We can't have the TEG lab just sitting around. It has to be run right away. And so those steps kind of have to be followed, whether you're in the ICU or the emergency room, in order for that TEG to be useful. Now, because we have that 2-hour leeway with the 6-hour and 24-hour draw, if you mess it up the first time, you actually will have an opportunity to draw another one. And if you have an art line, that's not too terrible. So there's a little bit of a buffer. And like I said, we will have that information all readily available at your fingertips.
And also just a reminder with the TEG, if you do draw it from a central line or from arterial line, you do have to waste 10 mLs of blood before drawing the actual TEG sample. So that
I have a question.
Yes.
So Dr. Bird, we are on the whole blood arm, and we've sent a TEG at hour 6, and that TEG comes back showing with the results saying that our patient just needs platelets. Will we keep them on whole blood, or will we use the TEG to determine next steps of care?
Yeah, that's boy, I think we need to go to the blood bank for that question. So the basic strategy that you basically receive whole blood as your therapy until two things happen. One is you stop the massive transfusion protocol, which happens either the patient stops bleeding and survives, or the patient unfortunately dies from hemorrhage. So if the MTP is ended, then we stop giving whole blood. So if we're in the whole blood arm and the patient has a TEG study which suggests that the patient needs some component therapy, we will continue with the whole blood until we finish the MTP. Now, for practical purposes, that's going to be a most unusual patient that's going to make it to 6 hours and still have an MTP activated based on their original activation in the trauma bay. But that's the way that we'll proceed with that. Basically, because it's the whole blood has platelets, it has plasma in it, so you actually are giving those components when you give whole blood.
And if I'm an ICU nurse, I would get whole blood from the blood bank. Is that correct?
Yeah, you'll get whole blood from the blood bank, and the study is all set up so that we have, in order for us to enroll a patient, we have to have enough whole blood to really transfuse the patient. And I think it's 8 units, right, Aaron? We need 8 units on standby. And if we don't have 8 units of whole blood on standby, the study gets paused until we can get that blood back. So imagine a patient comes in and we bleed so much that we use all those 8 units. And then an hour later, a new patient comes in. We would put the study on hold because we just don't have the resources to do the whole blood arm for that new patient. And we would wait until we replenish our supplies and then restart the study.
Just 2 things I wanted to note is that, like Dr. Bird said, the 8 units of whole blood is the max that a patient can get for this study. And then 2 is that if MTP is reactivated within 24 hours, that same randomized blood product should be given to the patient. So if we're in the whole blood arm and it's reactivated within 24 hours, then they continue to get whole blood. If it's after 24 hours, then they can resume standard of care, which in our case is component therapy.
That's actually good to bring up because we've had several patients that have had massive blood transfusion in the emergency department, have been stabilized, and then about 8 hours later, they relaunched. So that's very helpful.
Yeah, thank you so much. And then can we talk about the blood that we are sending in the 6-hour mark and then the 24-hour mark? And Jen, you say that you're making packs. I think when I spoke with PICU educators, we were going to put them on the at the tube station, so they're easily accessible from all parts of the PICU. And again, Dr. Bird had mentioned that we'll only have about 10 patients a year. So again, this isn't something that we're going to be seeing a lot of, right? So we just want to make sure all the information is in there. The packs have instructions, or it'll have all the tag information. So when you do draw the tag, you'll have to call blood bank, fill out the tag form, draw the blood, and have that walk down to the lab, so that it needs to be given to a person. So it can't stand in their little plastic boxes to be processed. It needs to be processed immediately so that we can get the tag to the machine and get that processed. So Erin, can you tell us a little bit about it'll be a timed thing, right? 6 and 24. What are will there be a label that pops up so that nurses know that it'll be the research blood work that needs to be done, that needs to be drawn?
Yeah, so that should be incorporated into the order set is the labels that'll come up. And so that's just kind of like any standard order, and then you'll just print it out and put it on the tube. One thing I did also want to mention is that in order to figure out if this patient is a MATIC 2 patient, there will be a sheet that goes up with the patient from the code room. And this will say that this person's a MATIC 2 patient. And especially for PICU nurses, there will be certain action items for you to do, like these 6 and 24-hour tubes, and where to find the kit, and like who to call to 15 minutes before the draw and everything like that.
Perfect.
And what happens if it's 2 a.m. and I have a question? I'm not quite sure what labs to send, or if the patient's enrolled, who can I reach out to?
Yeah, so similar, right on that sheet that's going to go up with the patient will be a list of contact information about this study, all the Dr. Bird's contact information, and then all the co-investigators as well. And so if you have a question, an urgent question, there will be an am I on schedule to figure out who to call and contact. And on top of that, specific related questions you can target towards specific PIs of the study.
Okay. So the am I on schedule, can you tell our listeners what that is? A lot of our nurses probably are not familiar with am I on.
Yeah, so Amion is a program that's used for my most familiarity with it is used for call schedules, for physician call schedules, and we use it for our general surgery, trauma, burn call schedules. And we're going to create a special call schedule for the MATIX 2. And the MATIX 2 call schedule will be, if somebody has a question about some aspects of the study, there'll be one of the physician leads on the study that will be available to answer those questions 24/7 using this call schedule. And we'll get that information out onto our information sheet that we're providing to nurses in different settings.
Right. So Dr. Bird, just so people hear it straight from your mouth, if your name is on the Am I On call schedule and it is 3 a.m, they are to call you on your phone that rings at your house.
No. Call me if you have questions. If the pharmacists give you the information that the patient should be enrolled,
okay,
then we're good to go. There's nothing that we need to do in the middle of the night. Nothing we need to do at 3 a.m. What we will do now, if you have some kind of question, it's a question about whether the patient is suitable for enrollment, something about the process, we'll be available to help with those questions. But you can just autopilot this patient, just get the MTP order set going, just draw the labs, and we will deal with everything on the back end. When the daylight hours come, when I had a good night's sleep, we will make sure that all the labs were, processed properly, and then start working on getting consent from the family.
Perfect.
Awesome. And then Dr. Bird, can you talk about the TXA? I know there had been questions about if a provider thinks that the patient should be getting TXA, but that's already been randomized and it's a blind study. Is there a process in place for that to be given?
Yes. So the simple answer is yes. And the way it works is, we won't know whether or not the patient gets TXA or placebo. But imagine a patient comes in the hospital, they're enrolled in the study, they get TXA or placebo, we have no knowledge which one, And then 3 hours later, 4 hours later, 5 hours later, there's some reason that we say, listen, this patient's bleeding, and we really wish we had given TXA, and we believe that, what, we don't care about the study, anymore. We just really want to make sure that we're doing everything we possibly can for this patient. Now, it's not part of the reason we're doing the study is we're not sure if TXA or giving nothing makes a difference, and that's why the study is being done. So if you have some strong belief that TXA is going to suddenly make your patient stop bleeding, well, this study is going to answer whether or not what you believe is true. But anyway, suppose you said, I want to 100% make sure this patient gets TXA. What we will do is you just need to contact the physician team needs to contact the pharmacist, the pharmacy, and they will contact the emergency department pharmacy or the investigational drug team pharmacy, and they will give you a packet, a medication to give that patient. And that medication will be the opposite of what was given in the trauma bay. So if we are in the year where we are giving placebo, the packet's going to have TXA in it. If we're in a year where the patient would have gotten TXA in the emergency department, the packet will have placebo in it. So one way or the other, the patient gets TXA. And so this was designed as a rescue. And when we do in this, when we do it in this way, the investigators, our team and the clinical team, you who are taking care of the patient at the bedside, won't know which arm of the study we're in. We will still not. So the next patient that comes in, we won't say, oh yeah, I figured out from the last patient that they got TXA. And so they're saying TXA versus placebo, but I know secretly it's TXA. No, we will still have known. So the reason it was done in this way is so that the investigators and the clinical team will be blind to what part of the study we're in.
Thank you. And then we can continue the integrity of the study. And then in the trauma bay, Jen, this is for you. You know how a lot of times we tell our nurses if we know that a hemorrhagic patient is coming in, penetrating trauma patient is coming in, and get the Belmont ready for blood, right? Let's pre-prime it. But we won't be able to know if the patient is eligible. So we won't know if they are going to get component therapy or they're going to get whole blood. What would you like us to do for those patients? How can we prepare them so that we don't delay in getting the therapy to patients?
What I would suggest is that for all our patients that we think are going to potentially need blood, to go ahead and prime with normal saline. If the patient rolls in, we definitely know they're going to get blood. If they meet the criteria for Maddox 2, we'll choose whole blood and we can get that out. And it takes a few seconds to spike that. And then you can just reprime the system to push that saline out and then prime with blood and get it to your patient. And that way we're not. What you hate to do is have whole blood primed and they don't meet eligibility and you got to switch it to component therapy or vice versa or throw all of it out. So I think the best bet is just going with normal saline until we have an answer. And with that, just so everybody's really clear who's listening, you can put whole blood through in the Belmont. It will not tear it apart.
And we talked about this yesterday, and I think this is there's been a lot of good things that have come peripherally. We haven't even started a study, and I think there's a lot of sort of good things that have come out of this. And I think, talking with Jen and Joanna, I think it really should be best practice that we prime with saline not to waste blood. So even forget about the study, forget about Maddox 2 happening. Our best practice should not be to put blood on the Belmont before a patient arrives when it takes only moments to put the blood on the Belmont once they arrive. And this is a way that we can still administer blood in a timely fashion, but not waste blood for the patient who we had misinformation about their likelihood of bleeding. And all of a sudden we've spiked a unit of blood and now have to throw it away. And I think that forget about the Maddox 2 study. That's just sounds like best practice.
Yeah, so lots of good things coming through with lots of conversations that were started because of the study. And it's gonna be interesting, right? We have to see how the study rolls out and see what needs to be ironed out. But we want everybody to be successful, so we have a lot of information out there. So as Erin had said, when a patient is enrolled in the MATIX 2 study, they will be an informational paper will be going up with the patient. And so on that paper, there is a FAQ, there is a part for the nurses to remind them that there is a timed labs that is going to be popping up for the 6-hour and 24-hour draw. And please remember those 6-hour and 24-hour draws are going to include a tag as well as a study for labs for the study specifically. So if you have some questions on what lab stickers are printed, please contact the pharmacist that is also part of the study, or just give the researchers a call during business hours. And then also we do have those packs for those the patients that are up in the PICU that will be readily available, that has the vials that are specific volumes for that we need for the study. So the 2 ml volume vials for the light blue as well as the purple. In November 1st, here we go. Hopefully we'll be able to get a patient. We never want a sick patient to come through, right? But for research purposes, we hope that this does give us more information on how to properly treat a hemorrhagic patient. Dr. Bird, any last words that you want to include?
I just want to thank the nurses and other members of the Children's National Medical Team who will have helped us with the study and will help us with this study. I know there's a few activities here that are outside of what you normally do for clinical care, and these are sporadic patients. So every time we do this, it will be sort of reinventing the wheel. But I just want to convey that I think we really appreciate the help that you're doing. We are, this study has been an act of love for us. It's like we're losing a ton of money on the time that we spent on this to make it happen, because we believe that this is going to have an important result for injured children. And so on behalf of us as investigators here at Children's and the children that we're serving, thank you for spending the effort to do these hopefully small extra steps as part of the work that you do.
Thank you. Erin, any last words that you want to include for our care team?
Dr. Bird said it so eloquently. I'm going to leave it at that and say thank you as well. Yeah, my contact information will be on that sheet. So if you have questions, please contact me.
Awesome. And then Jen.
I always have last words. Just remember, there's a lot of resources. The resources will be in the pack. The resources will be on the CN Trauma app. And I am just finishing up updating the trauma intranet site. And so we'll have these instructions there also. So there'll be a lot of places that you'll be able, other than just a phone call to somebody, to figure out exactly what it is you need to do. If at any time you look at any of those resources that we've given you and something isn't clear, please let us know, because we are happy to edit and make things clear as you as the end user are looking at them.
And as we're rolling this out, we have created PowerPoints for the ER nurse NALs as well as the PICU nurses. So please reach out to your educators and they will be able to provide you with a little bit more just written information, just so that you know what things look like. And for the different modalities, we want to make sure everybody is covered. So more information will be coming out. Please check your educator near you. Great. Thank you so much. And happy Halloween. I hope everybody had fun. And then the next day we will start MATIX 2. Thanks, everybody.
Thank you.
All right.
All right.